Hello, I'm Dr. John Kruse, and welcome to today's question and answer session, where I will try to answer questions about the videos that I've released on YouTube in the past week, other ADHD topics, and mental health in general. The warnings or things I should say in advance are that the information here is presented as information, so it's not direct medical advice. So take whatever information may be pertinent to your life and share it with your doctors and consider whether parts of it may fit your situation. Also, I will say that since I've gotten a fair number of comments and messages about this, I am not taking any new patients at this time. I haven't since I've moved to Hawaii 3 years ago. I'm trying to spend more of my time and resources educating a broader swath of people through my videos and writing. And the third message, or third and fourth, before we jump into the reviewing the two videos and then the questions themselves, today and tomorrow, I believe, are the ADHD Entrepreneur Summit, where I and a bunch of other ADHD experts offer pertinent practical advice on how to deal with ADHD or how to channel ADHD for setting up your own business. The fourth thing is the shout out to the Reddit subreddit channel, if that might be a better opportunity venue for discussing or commenting on some of the topics in the videos. So the two videos released this week, one was a re-recording, Max fixed up the sound for neurofeedback and ADHD. The second was on suicide barriers and the Golden Gate Bridge. That was a new video. So that the neurofeedback for ADHD, the unfortunate summation, and that video came out, I think, about 2 years ago. This very week, there was another meta-analysis that got lots of attention. I think it was actually released a few weeks ago, showing again that neurofeedback for ADHD has not been proven to be terribly effective. And the summation in the current meta-analysis was that there did not seem to be any clear-cut clinical value, and even if you looked at specific neuropsychological variables, maybe you could find a small effect on reaction time getting faster, but effects on attention, sustained concentration, on working memory, either verbal or visual, were not impaired and not improved by neurofeedback. Now, that doesn't mean there might not be some protocols somewhere that really do help people with ADHD. It's just that most of the benefits in most of the studies could be just a treatment general effect that you're in a study being examined for your ADHD. And we certainly, given the amount of money and time that treatment costs, they should have much better studies showing that it works well by now. Second video was on suicide barriers and the Golden Gate Bridge. So the Golden Gate Bridge is considered one of the most prominent suicide magnets in the world. So more than 2,000 people have traveled there in the 80 years since it's been constructed to kill themselves. And in the last decade, that's averaged about 30 a year. After 7 years and $400 million, a barrier to prevent suicide was completed in November of 2023. And in the years since then, there was a recent small report issued. Only 8 deaths were documented. They do have 24/7 cameras on the bridge. So unlike in the more distant past, where we know many people who jumped, bodies were never recovered, so the count was almost always an undercount, the 8 in the last year is almost certainly a realistic, accurate count. So that's a dramatic decrease. It's not zero. So one of the things I talk about in my article and that I've written about it and in the video is that they promoted this as this would eliminate suicide at the bridge. So clearly deaths are down at the bridge, but my contention is that almost certainly most of those who would have gone to kill themselves at the bridge just went elsewhere. They did not just give up on the idea of suicide. So I think this is a well-intentioned effort, but not a thoughtful enough effort, and that $400 million would have saved many more lives if you had spent them on $5 trigger locks and disseminated those widely to make gun deaths less likely. I can go into details of that discussion if anyone is interested in that, but I see there are, several questions, which I will get to right now. So, hello, Dennis, again. Dennis says, Dr. Robert Melillo, neuroscientist, said that ADHD is a right brain deficit. Increasing the right brain activity increases novelty seeking, just like ADHD. How can both be true? Yeah, I haven't read his specific arguments or discussions. And I've spoken about left brain, right brain differences. I think almost all the time when we're talking about circuits, we are making oversimplifications. Sometimes they're useful oversimplifications. And some, particularly the left brain, right brain, and attentional systems metaphor, there may be some laterality, but I think it's more emphasizing there are discrete different systems for attention in the brain. It's clearly both sides of the brain are involved in ADHD symptoms. That's where I'll leave it. I won't try to parse it more specifically, I guess, right now. Maybe we'll come back to that. And hello, James Alexander again. James asks, what psychiatric disorder, if any, the Yiddish phrase neb might be describing? If nebs can be described as people who struggle socially, lack grooming skills, have poor body awareness, are messy eaters and messy in general, lack executive function skills, and are slow to pick up social cues, self-conscious, and are socially and generally anxious, are a little paranoid, struggle with flexibility, are slightly obsessive, and struggle keeping fast-paced conversation, and a million other things that socially normal people do on instinct. So my simple answer is probably all of the above, or maybe a better answer is that sort of social, cultural distinction of a group of people who are standing out from the norm is one way of classifying mental health conditions. The DSM is another. As we've talked in some of these videos, the DSM tried to purposely avoid identifying an etiology or origin for the conditions and relied on a descriptive set of words to identify each condition: OCD, depression, ADHD. And that's been of some utility. It's not been garbage, but clearly most people who have one mental health condition have more than one. There clearly are people who have pure forms of OCD, pure forms of depression, pure forms of bipolar disorder, pure forms of autism. I'd say some of the beginning attributes of NEB certainly fit with a autism spectrum, sort of being socially unaware, not following social norms, and not even being aware of what they are. I'd say some of those also being the messy eaters and messy in general. I pick on this. I was a chaperone back when my kids were in second grade for a kid who and one of the kids displayed a huge range of ADHD symptoms. He took his backpack up on not the ski slope, but the sledding slope, literally 12 feet tall, not any taller than that, and had things falling out of his backpack on the 15-yard hike to the slope. I helped him put them in the backpack, zip the backpack up. Before he got to the top of the 12-foot slope, he had dropped 3 additional items: a mitten, a set of playing cards, I think some pencils, out of his backpack. And when we talked about that messy eating, the kids were eating, I think, 6 or 8 to a table, but at the end of every meal, I could identify where this kid had sat because there was a penumbra, a cloud of crumbs in the vicinity of wherever he had been eating. So some of these sound like ADHD. Some of them may be social anxiety disorder. So I don't think that our DSM is going to map perfectly well onto other social cultural ways of splitting up mental health conditions, is I guess what I'll say. Flynn asks, or Max, hi. Is there something particular with depression and or suicidality that the individuals who suffer from these tend to be adept at concealing it from others? I mean, one of the factors of depression is social withdrawal, not wanting to communicate with others, or is often how it's phrased. And I think the DSM phrases it something like that. But I'd say, and I think they may even address this angle, but more than just wanting to withdraw from others, often a huge element of self-thought and self-worth in depression is tied up with, I feel so miserable. My depression's such a burden on me. I don't want to share it with others because I know others will treat it as a burden and maybe also be less likely to like me or supportive of me, but feeling that their burden, others are going to experience them like they experience their depression. So I think that contributes to not wanting to share, not wanting to infect or inflict their feelings on others. Very clearly, the subset of individuals who become intently focused on or seeing that suicide is a way out very often intentionally conceal it because they don't want their plans to be interfered with, again, separate from or parallel with feeling that it may be a burden on others. So Shul asks, how would I evaluate Donald Trump's current behavior from a psychiatric standpoint? Would you say it's consistent with your previous assessments on this matter? So my previous assessment or book describes how he fits the full criteria of ADHD symptoms. I mean, I think those are there. I think one of the things that's very different this term than the first term is that I'm not sure his amount of chaos is any greater or larger, but at least many of the people around him in his cabinet and sub-cabinet, and there's always been a lot of shadowy people who are behind the scenes, and this has been well documented. This is not paranoia. People who made decisions at the Department of Veterans Affairs who were not the cabinet secretary in charge of that. Anyway, in the first administration, he had some people who tried to normalize him, tried to cover up the worst of his excesses, of his chaoticness, of his sporadicness. And in this administration, they have intentionally tried to and effectively have weaponized his chaoticness. So I don't think that makes the chaos itself a strategy of Trump. I think that's part of who he is. Two is, I think there is clear and robust evidence, most precisely from his use of language, the words he uses, the pauses, the incoherence in terms of just one sentence follow another. There's been clear declines that are in excess of what one would expect with aging. And again, although these on the surface make it look like ADHD is intensified more, ADHD usually would not be changing from someone's early 70s to mid 70s or late 70s. So I think there are clear documentation of dementing condition. What that is, I don't know. What else would I say? I'd say the other thing in terms of evaluating what he's doing, I think if you've seen the movie The Apprentice, where the 3 lessons from Roy Cohn that Trump seems to have embodied, the more you're aware of those 3 rules, they seem to cover virtually everything Trump says or does. 1 is attack, attack, attack. 2 is deny, deny, deny. And 3 is whatever you do, claim victory. So I've seen on online forums people praising, Biden in 3 years couldn't achieve an agreement or negotiation with the Ukrainians, and in Trump's first week or month, he, has gotten us mineral rights to exploit there. 1 is, as of today, which is mid-April, more than or almost 3 months in, we do not have any signed agreement with the Ukrainians. But Trump announced how victorious he was, and all of his followers seem to follow or accept that. So I think psychologically, does that feed in with narcissism? I was more reluctant 8 years ago, to diagnose him with narcissistic personality disorder because you need to know intent, but he has shared so many comments where we know his intent and motivation. We know how important it is. We know how grandiose he is. We know how little care he has shown for others. So that's where I'll stop on that. So James Alexander has said, has any of your ADHD patients failed to benefit from any kind of medication? No, I'm trying to think of anyone who's shown absolutely no benefit. I'd say much more common is the commonest thing is people respond and overall they feel that the benefits outweigh the risk, that the downsides are getting. There's some sizable minority who clearly got benefits, but either agitation, over-arousal, some other clear-cut common side effect with the medications, or an uncommon one like psychosis, interfered with them taking medication that worked. I'd say the number of people I've seen who got no benefits is much smaller, but there are probably a few. So I'd say no benefit is much less common in my experience, and I don't think it's just that I'm tremendously more innovative or skillful with using medications. I think that's more a reflection of the people out there. There is some aspect of who doesn't benefit. I'd say particularly in some cases of secondary ADHD, so whether it's from long COVID, whether it's a chronic fatigue, neuromyositis picture, whether it's direct head trauma, I've seen, I'd say, lower rates of response to traditional ADHD medications than in classical, defined, arising from childhood ADHD. So Schul is saying that Trump's actions appear to have been even more unpredictable, or at least more consequential than the past. So again, I think, to me, I do think there's some decline in his capabilities, but I think far and away there are people, the authors of the 2025 agenda, whatever they called it, who wrote that out years in advance and lobbied to be included in this administration. There are, when Trump got in the first time, all of the evidence is robustly there that he himself did not expect he would get elected. And he was completely unprepared. And as someone with ADHD, he had not done any of his homework. He was extremely slow staffing up and relied on traditional party channels to provide the pipeline for who he would be staffing with this time around. And again, many of them were maybe even part of the deep state who believed in normalcy and taking care of business as usual. The crowd that's around him now have a very different philosophy, and again, have been very adept at weaponizing Trump's unpredictability. Again, I'm not sure that Trump himself is that much more unpredictable or chaotic. I think some of the content is a little more bizarre than last time. G said that I've mentioned that the right inferior frontal cortex is less active in those with ADHD. Can a stimulated left inferior frontal cortex help to overcome that lack of activation in the right? Yeah, so I mean, the commonest thought would be if you're directly stimulating one hemisphere compared to the other, then you are primarily stimulating that hemisphere, and it wouldn't automatically result in activation of the alternative hemisphere. But again, I think with many, the lateralization in ADHD is, the prefrontal cortex is clearly important. Whether left or right is more important, I think, is more nuanced. And I think, we have more clear-cut evidence of laterality in something like depression, but even there, it's fairly nuanced. There's a lot of individual variation, and that's, I think, where I'll leave it, because I'm sort of reluctant to oversimplify. And I am not just reluctant to oversimplify, I just am not current with all the most recent studies that may reveal more substantial lateralization differences than I'm aware of. Mr. AKA says, what do you think about contingency management or giving money rewards to addicts who can prove continued sobriety? I'm thinking particularly of folks addicted to opioids. One of the things that I think is that the evidence is pretty clear-cut that it is one of the more effective strategies, behavioral strategies we have. In other words, in a lot of settings, from incarceration to avoiding incarceration to nowhere related to the penal system, studies show paying people to stay clean, and some of it's sort of the constant feedback, reinforcement, monitoring, knowing that someone else is there, but also getting some immediate payback works. It's not completely effective. It doesn't prevent all, but it measurably reduces use. So I think it's something that we should be encouraging rather than applying moralistic terms to not use it. So Luke says, I fear side effects of medications. Are Ritalin and Vyvanse the safest options? So when bodies like APSARD, which is the Association for ADHD Research and Related Conditions, and pediatric organizations, others, the evidence is that amphetamine-based products are the most effective. Maybe Ritalin-based products are close to as effective, but in all age groups, the amphetamines do have more side effects than methylphenidate Ritalin. So just in terms of side effects, Vyvanse as an amphetamine product probably does have more risks than Ritalin. Each individual is different, so there are certainly people who do fine on Ritalin. There are people who do fine on Vyvanse. There's people who do fine on dextroamphetamine for decades. Among the amphetamine products, I think there is growing evidence that Vyvanse is one of the safest options and may have, there have been studies looking at it in people with addiction disorders, and it seems to be safe and effective for treating ADHD symptoms in that context, while at the same time, not just treating ADHD, but decreasing the likelihood someone will use their substance of abuse. So, of the Ritalin products, Concerta tended to be the one that I've used most often. So a slow release form that's an osmotic delivery. Vyvanse is a slow release form of dextroamphetamine with a prodrug model that makes it a slow delivery system. So I can go into more specific side effect questions or details if they're there, but I'd say if we're making general, if you're focused just on side effects safety, then you should probably start with something like guanfacine or duloxetine or atomoxetine. James Alexander asks, why is it more socially acceptable to disparage people with bipolar disorder, borderline personality disorder, antisocial personality disorder, state that you refuse to date or friends with them, and attribute difficulties in relationships with them on their poor behavior to their disorder, than it is to speak in the same way about people with Asperger's syndrome, autism spectrum disorder. I won't try to justify or explain. I don't think that there's a rational reason for how social rules come up. I think in general, over the 30 years I've worked, it's certainly become less socially acceptable to disparage anyone because of their mental health condition, but we still see it across the media, and certainly blurring politics. And I mean, there's clearly one political party that thinks it's much more socially acceptable to disparage people for their existing conditions, whether it's whatever they are. I mean, it's interesting that autism spectrum conditions have been in some ways more adept or socially clever at fitting in with our current society, or exalting or presenting it as a superpower, or some of it's framing it as neurodivergence. Some of it has been an expansion of the diagnosis there, so that we're covering people who clearly would not be considered to have a condition by older versions of DSM, but are now on the spectrum. So part of it, it's including a milder group of afflicted people. So that's, I think, changed social attitudes, but I'll leave it there. I don't think I'm answering that very articulately. So, but to sum it up, I think neurodivergence is clever marketing. I don't think it was designed to be clever marketing. I think it reflects a reality, but I think you could certainly make the case that bipolar, borderline, all these other are also neurodivergent conditions. I'd say the data, and I was reviewing a study recently about just hospitalizations, ER visits, and there's marked differences between the ADHD population and the ASD population, even given that there's a lot of overlap, individuals having both, but kids with ADHD or adults are more likely to run into situations where they injure themselves. Whereas ASD certainly, and particularly certain types of injuries, like injuries with animals, are markedly less likely with ASD. So part of it is with ASD, if you are less likely to be socially interacting, your impact on others' behaviors is, you might be considered weird or different. You're not hurting them. Whereas people who are out there acting without concern or awareness, so with ADHD, it might be you're not aware of how you're standing too close, how you're cutting people off. You might not be aware of, with narcissism, you're maybe intentionally or unempathetically doing some of the same things. So conditions that more clearly hurt other people, I think it's not surprising that there would be more social opprobrium directed towards those. Tom asks, between Pristique and Cymbalta, what have you noticed? Preserved energy and range of emotions better? Taking Lexapro for 3 weeks and tired with brain fog every day, even when taken with a stimulant. So Pristique is a version of Effexor, venlafaxine, and Cymbalta is duloxetine. And there's a marked difference between venlafaxine and Cymbalta in the relative serotonin to norepinephrine. So both of them are stronger on serotonin than norepinephrine. Duloxetine, Cymbalta, roughly balanced. Venlafaxine more than 100-fold stronger on serotonin than norepinephrine. And Pristique is a little better than venlafaxine, but still relatively more serotonergic. And people who are particularly sensitive to the differences between the two are less likely to feel either stimulated, alert, awake with Pristique than with Cymbalta, is what I've seen, which would sort of correlate with the neurochemistry. Svena asks, is there a concept of slow suicide in psychiatry? Someone who engages in continuous actions that are self-destructive or of extreme negligence to their own body, knowingly leading to their own death. So I think there's a huge amount of discussion in the literature, particularly with substance abuse. Someone who, part of the definitions of addictive behavior is that you're continuing doing it knowing that it's harming you, so you have some awareness and that you try to stop. And whether those are considered suicidal or parasuicidal, so related to suicidal conditions. But it brings up a whole lot of questions and issues, whether it's depression, whether it's a substance abuse, how much autonomy do you have? Clearly you have some, but clearly your autonomy is impaired by your very condition. If you have an addiction, it is harder to say no. If you have depression, it is harder to get out of bed. If you have ADHD, it is harder to brush your own teeth regularly. And yet we know oral hygiene doesn't just have a long-term impact on your teeth. It has risks of generalized infections in the body, cardiac health, other parts of health. So I think the field, and I would sort of agree with this, wants to reserve suicide for clearly intentional desire to kill oneself or to harm oneself, and is more careful about using that term in terms for people who are maybe unhappy with life, maybe despairing, maybe don't see solutions, but aren't directly, explicitly wanting to die. Have you ever had patients who were in denial over their ADHD, and did any of them never come to terms with their diagnoses? So I've had 3 are jumping out at me, and I've talked about each of them before, and I'm trying to use details to discover them. One of the saddest was a woman, professional journalist, in a long-term relationship, had at least 2 daughters with her wife, and had been in therapy with a very well-respected psychiatrist therapist who, for more than 12 years, focused on how this woman was self-sabotaging herself. She'd show up late for appointments. She wouldn't pick up her kids from school on time. She would get into arguments with editors. She would be late for deadlines. And yet neither of them could find a reason, after 12 years of in-depth psychoanalysis, for why she would want to be self-sabotaging herself. She had a depressive episode, which was different from what she had experienced in the past, and that's when I saw her. And in addition to the depression, everything she discussed, from poor time management to poor impulse control to problems organizing her thoughts and even inattentive and distractedness, it was pure, classic, robust ADHD. And I'd say with her, I only saw her, she only came in 3 or 4 times. Intellectually, she got to a point where she could understand that, yes, everything she described was actually an element of ADHD and maybe not self-sabotage, but this was a very compassionate, intelligent therapist. She was just so wedded to her therapist's view of herself that she did not decide to pursue treatment with me, and I don't think ever did again. More commonly, I've had examples of people who came in thinking they needed anger management, or coming in with an addiction disorder, thinking they are coming in for other situation where ADHD wasn't on their radar at all. And many of them were initially, this couldn't be ADHD. I don't believe it. I don't understand it, but usually with understanding and explaining how well their symptoms map to it, they could see it and understand it. I've also had people who came in denying that they'd ever been diagnosed before with ADHD, and then only after multiple sessions of the same process, where we reviewed what they're doing and how they're behaving and what they appear to look like to others, and then only at that point conceding, well, yes, 20, 30 years ago as a kid, they had been diagnosed with ADHD, but they had been made fun of. The medications had bad side effects. They didn't like it. They felt so stigmatized by that earlier go around with ADHD that they wanted to deny it. But again, most of those did, particularly when I could, at the first session with them, pick out, this seems to be the primary issue that you are dealing with, not depression, not something else going on. There's one of the other saddest scenarios is I was a 70-year-old woman, this is almost 20 years ago, who again was being treated at the university for depression, and yet absolutely everything she described from childhood on was classically ADHD. And at that time, maybe it's 25 years ago even, that the university psychiatrist, well, ADHD doesn't exist in adults. It certainly doesn't exist in 70-year-olds. They also, they were the university professors. I was just a recent graduate. Who was she going to believe, even though I thought I made a compelling case to her? So yes, I've seen a handful of people who remained convinced that they didn't have it when I was quite convinced they did. So good morning to Ian Fraser, who is in New Zealand at 5:30 and is awake for this. So great. Luke brings up, I have suspicions that I have ADHD symptoms and it's being harmful to my life. What are the first steps I should take? Should I go straight to an available psychiatrist, take an online test first? So again, I can't make specific medical recommendations. And even what I would say is there's almost no lag time for taking an ADHD test online. So you can do that quickly. What it will do is will highlight symptoms that may be present in ADHD. It will not tell you definitively that these symptoms are coming from ADHD. Again, we know depression, anxiety, bipolar disorder, dementia, post-COVID, all sorts of conditions can mirror, mimic, replicate ADHD symptoms, but it could provide some reassurance that, yes, I'm at least looking in the right direction. My recommendation is that if there are symptoms that are impairing your life or interfering with it, yes, you should go to a mental health expert. And I think you actually should go to someone with some expertise or awareness with ADHD, because even though awareness has grown over the last 20, 30 years, and I'll say maybe in the older days, it was an emphasis on focusing on depression or bipolar or anxiety and completely missing the ADHD. I'd say maybe a bigger pitfall now is trauma-oriented therapists. And I have my PTSD and ADHD talk here, who can only see trauma and can't see ADHD when it's clear in there in front of themselves. So, the downside is it will probably take longer, be more work and money to find a psychiatrist. But if it's really impairing your life, then I don't think you're likely, and particularly if it is ADHD, you're not likely to resolve it on your own if your current life circumstances have not led it to being resolved. So Ian Fraser is asking about drugs that are used as mood stabilizers, carbamazepine, which is Tegretol, sodium valproate, Depakote, and lamotrigine, Lamictal, that are being used. So those are drugs all of these are actually initially anti-seizure medications, anti-epileptics, and all of them have been FDA approved for use as mood stabilizers in bipolar disorder. And the question is, does the effect on kindling that reduces seizures have a negative effect on education? So I am not aware of any, and I would think that given that having seizures both from a neurologic level and from a social disruptive level can affect learning and education. If you have seizures, that would be good for them. In terms of intellectual impact or learning impact, particularly compared to some of the other drugs we use in psychiatry, these tend not to be high up on the sedating and or intellectually impairing, and particularly lamotrigine seems to be very lightly impactful in that dimension. So Ian's pointing out that learning requires making pathways, using them repeatedly, which so we're sort of, I'd say, delving into the differences or different types of neuroplasticity versus kindling. They're all have at their core the concept that the brain, if the brain practices something enough, then it strengthens the pathways, the connections that are being practiced, and the unpracticed conditions or connections are weaken, or they usually don't disappear completely, but they are less accessible and less readily used in the future because they haven't been strengthened. But I think, one is you can have neuroplasticity working in different directions or different ways, different parts of your brain and different. So I don't think, even though the drugs may be having a global effect, again, there may be data on this. I'm just not aware of any data showing that these drugs that have anti-kindling effects are preventing learning. There. So Tom brings up that I mentioned the call of the void in my latest video, and that's a behavior he never knew was a normal self-preservation in healthy individuals. Are there variations of how it can present in ADHD and OCD? So it was in the talk on the Golden Gate Bridge where the call of the void is a sensation that some people and some surveys show that there's only a handful of surveys, anywhere from 30 to 60% of people without any mental health conditions can have this feeling that when they're near a tall edge, the edge of a building, maybe the Space Needle in Seattle or something where people have a sudden, and it's often described as an urge to hurl themselves over, could jump over. I've experienced what I think is this, and for me, it's more the initial fear. I just said it. The initial sensation is more a fear. A fear is like, I could do this. It's not even a desire to do this. Others may experience it more as a desire that they know some other part of them doesn't want to. I think there are parallels or connections to, particularly with OCD, some are common, not that uncommon. Fear is that they're going to do something highly dangerous. So if you're on a subway platform, the fear is I may jump in front of the train. I don't have any desire to, but I'm worried that I might. Or if I'm driving, oh my God, I could swerve into that line of oncoming traffic. So there's, I'd say, some overlap or connection. That the point of there's the number of studies on call of the void is, I think, less than 5. So there's just very little that's actually been studied about it. And particularly it was looking more, the ones that have been done have been looking at, is there a connection between this and suicide? And it doesn't seem to be that people who experience the call of the void are more or less likely than others to be suicidal. But I think it would be an interesting topic for research. So James Alexander is, how can we continue making moral judgments of people's motivations and actions while taking a dimensional view of mental illness? How do we morally distinguish bad people who can be blamed for their actions from sick people who can't, if ADHD, ADSD, etc., are just broad swaths of the range of executive function, social functioning that exists in humanity? I think that's a wonderful question. I think what's sort of shocking to me is many critics think that the insanity defense, it gets played up in dramatic cases, is widely overused or utilized. And I'd say there are clearly huge number of cases where someone was completely psychotic and we are treating them as if they were premeditatedly evil. So, I mean, one is I think it's useful to look at, if you kill someone, it isn't always murder. So our legal system does try to account for motivation and competency awareness of the impact of someone's actions. So if the condition, it's dark conditions, someone's not in your full view, you hit them with your car, that may be considered just an accident. If you were driving a little faster than usual and one of your headlights was broken and you hit the same person in roughly similar conditions, that might be considered negligence rather than just an accident, and there may be some charges there. Or it could be considered manslaughter. Or if you're doing it out of a fit of rage or you are impaired by alcohol, then it gets a different category of killing someone. Or if it's your arch enemy who just did you bad in a drug deal and you intentionally aim your car and hit the accelerator and run them over. And so our current legal system does already try to incorporate some of the range of motivation that's going on and separate out. But I think neither our mental health system nor our legal system has a good way to sort out what is blameworthy and what is not. And the other side of it, I've seen, including there's a sizable number of psychiatrists and mental health workers who say, you shouldn't be providing clean needles and other things to drug users. You're making it more easy for them to use, and you're not holding them accountable for their actions. And each of us has our own accountability. So there's no unanimity among mental health workers. I don't know. I think it's a big issue that society is going to need to continue to be exploring, and maybe we'll explore it more through AI, because how intentional is AI? I mean, we try to pretend these things are completely inanimate and couldn't possibly be thinking in terms of intentionality, but I think that may be a useful way for some of us to think more about what's going on in humans' brains is what's going on in comments and actions executed by AI. So Max asks, are you aware of any studies looking at factors to interpret variations in suicide rates by country? One would think the top would only be the poorer countries, but there's the USA, Belgium, Finland as well. So there is a lot of epidemiologic study in suicide. So some of the things that have been looked at are sort of industrialization. Some of the things that have been looked at are sort of misery rates and unhappiness rates. So countries like Iceland, which is far north and long cold winters, do have higher suicide rates than many other parts of Europe. Clearly in the US, and the Second Amendment fanatics don't want to accept it or believe it, but accessibility to guns, to an easy, highly lethal, easily accessible mode of killing people does have a substantial impact on both suicide and murder rates. So often the two are studied in conjunction, and the US is, rate of murder is at least an order of magnitude higher than most of the other countries that it compares itself to demographically. And so part of the difficulty is we can make epidemiologic connections and correlations, and that doesn't, there's also social attitudes. So, different cultures, different traditions. I mean, so one thing that's people aren't aware of, the age group that still has the highest rate of suicide in the US is old white men. And yet we focus so much on kids, and I think we should. So rates in kids have been going up more quickly. They are approaching those of older generations. And yes, when a kid dies, it's easier to think they were making a rash, impetuous, not well-reasoned decision because they haven't had enough life experience. And they have deprived themselves of decades of life, whereas a 70-year-old is probably at most depriving themselves of a shorter number of years and maybe more physical misery in it. So what I was getting at is we can come up with theories, we can come up with correlations, we can see what the statistics show, and that doesn't always tell us what's going on in the minds of the individuals themselves. So Ian Fraser, no need to apologize for no questions off topic, because my topic here is mental health and human beings. So it's all related and connected. And those who don't want to hear about a specific topic don't have to listen. Hopefully we'll get back to something that's more interesting to them. James Alexander asks, do I think the clonidine patches, which release medication at a constant rate, differ in their effectiveness from the instant release, extended release pills, which provide variance in blood levels? So with stimulants, there's clear data showing that how quickly dopamine receptor reuptake is blocked, how much dopamine's flooding receptors. It's not just the absolute amount, it's how quickly things are changing. So rate of administration is important. I'd say particularly for the ADD benefits, and as my understanding, many of the blood pressure benefits of clonidine are slow and indirect. So I don't know which of their effects would be different in an immediate release form than in the patch form. I'd say part of what, particularly with clonidine, one of the biggest problems with clonidine as a blood pressure medication or as an ADD modifying medication is that clonidine has a fairly significant rate of, if you miss a single dose, if you're taking it daily, or stop cold turkey, it can cause rebound hypertension, and it's not just leaving you back at the blood pressure level that you were taking it for, which is already elevated. It can be shooting that up to ridiculously high levels. So having a patch that's on for a whole week eliminates 7 days of chances of skipping a pill and putting you into dangerous hypertensive territory. So there are certainly differences in withdrawal potential with those techniques. Luke says, if I got tested for ADHD and the results came back negative, can I still consider taking ADHD medications for being extremely low in conscientiousness? I'm around first percentile and it feels like a curse. So I'm not diagnosing, I am speculating here. And if this feels too intrusive or personal, I'll back off. But I would say anyone who's worried about their conscientiousness is at least a little bit conscientious and probably is not in the first percentile. And right there on the surface, to me, that sounds more ADHD-ish than lack of conscientious or apathy or other things like that. So what I would say in a general sense is that, again, ADHD exists on a spectrum. The DSM has a clear cutoff on 5 symptoms for an adult. I'd say many practitioners accept and deal with that it occurs on a spectrum, and we know and we have research that medications can be effective in helping reduce symptoms and impairment in people who are at subsyndromal, subthreshold levels of ADHD. So, but some providers are more doctrinaire and dogmatic, and I mean, some won't prescribe stimulant medications at all. Some So I would say it's a matter of finding someone who is willing to work with you and who shares your philosophy and who can help you delineate, what am I trying to treat? How can I monitor whether this is really getting better or not? And also, how can I tell what are my side effects and adverse effects? And how can I balance, am I getting more benefit than harm from what's going on? So my bottom line would be encourage you to connect with the mental health professional community and find someone you can work with. Ian brings up that he's known people who are calmer when they have a good method of suicide. Is this something you've seen, or is there literature about it? There's, and I've not dipped into it recently, but there's clearly, some would say, and I think there's a quote from, it's either Camus or Sartre, and I can't remember which, saying that suicide is actually the only question. We are here, none of us, depending on your religious beliefs, but I would say none of us chose to be here. We do have a choice of sticking around, and that is the one important question. So someone who feels, I've worked with many depressed people who felt part of them, so almost always there's some ambiguity and some ambivalence about suicidal intent. So people can view it as knowing I'm going to die at some point and knowing that I have the method or could do it fairly safely, fairly not messily, fairly however, can often be reassuring and calming and actually help them completely step away from focusing and worrying and fixating on that. I've worked with a number of people that would be an accurate description, and I'd say people in that category, almost, I can't think of any that have killed themselves. So yes, having a plan, whether it's even a realistic or really a good plan or not, can be calming and reassuring and actually help them move away from their suicidal thought or engagement. On the other hand, for some people, the locking in on a plan is a scary step in the escalation and increased likelihood that they really will act on their feelings. So Max asked, in my professional opinion, is doing a Nazi salute a typical sign of autism? Sarcasm aside, it's pretty gross how mental health is always trivialized or weaponized in public discourse. Yeah, to me, so I'm assuming we're talking about Elon Musk, who at least on 2 different occasions has given a Heil Hitler raised arm symbol that he absolutely is aware of the societal assumption of what it means. So I don't think in these specific examples there's any pretense that he can claim an awareness of what he did or the meaning others would attribute to it. Again, I don't know what his motivation for doing it. I don't know whether it was spontaneously reflection of something, whether it was intentional trolling, whether it was intentionally trying to endear himself to the crowd he was speaking to or to the boss he ostensibly is working for, although it's not clear who's working for whom. So again, I think it's very hard to make any case that he wasn't aware of both what he did and he was aware of what meaning it would have to others. And yes, if you have significant autism, you could make a gesture like that. But even, if you're making that gesture, you are repeating something you've seen other people do, and it has some meaning to them. So it's not just a random innocuous gesture where you might go like, I don't know what you might do. All the gestures there, I think I answered what I can say intelligently on that. Ian brings up that New Zealand was the first country to have a government-sponsored needle exchange program. We managed to miss most of HIV/AIDS and some Hep C diseases. It's something that saved many lives. Yeah, absolutely. The research is there, that it's robustly clear that it saves lives from infectious diseases, and it saves misery and infections and abscesses, and it probably is a helpful initial step for those who eventually want to stop using, to have a positive exchange with the mental health world and know that they're just not going to be judged and condemned. So Tom asks, would I consider doing a video on beta blockers for anxiety and making stimulants more tolerable? So I'll write that down. It's come up before. I do have a lengthy list, and I'm less efficient in churning out videos than I had been before. So, but yes, that sounds like a worthwhile topic. I don't think there's a lot of rigorous research on using beta blockers to counter the potential side effects of stimulants. When I was looking at stimulants, I mean, there's a fair amount with guanfacine and alpha-2A partial agonists, guanfacine, clonidine, to make stimulants more tolerable. But particularly if there's actual research on it, then I'm more than happy to talk about it. Otherwise, it's more conjecture and theoretical and a little amount of clinical experience. So James Alexander, I'm not quite sure what the antidepressants equal SSRI and SNRI reference or question to, but maybe it'll come up. So Percocet ZH asks, what's the typical prior authorization of Medicaid in California for Vyvanse for the treatment of ADHD? So Medi-Cal, which is the California so Medi-Cal is Medicaid is a federal program for people with disabilities and low income, and Medi-Cal is a California administered version of that. I mean, I'm trying to remember specific examples. So part of it is that in California, counties administer their own versions of Medi-Cal, and each county has their own formularies, and some counties will absolutely. Vyvanse I've seen covered, but I've had some where that say modafinil or armodafinil. Doesn't matter that it works for your patient, doesn't matter that you've documented it's safe, doesn't matter that you've shown research that it's been utilized for this condition, we're just not approving it. So that is part of their legal authority, is they don't have to approve drugs that aren't on their formulary. But Vyvanse, I'm sure I've had people in more than one county where I've written treatment authorizations and had them approved. So thanks for the positive feedback, Percocet. I hope that answered. Philip S. is wanting to thank me for all my good work in education. Thanks. It's gratifying to hear that I've helped his daily life and routines and reduced many of the worries related to new diagnosis of ADHD. And Tom is chiming in that the videos have been informative and help to feel like there's a more collaborative approach. So good. That's, again, so I've worked 30 years. I still have some patients I've worked with for more than 25 years, but I've been trying to do less work with individuals. I find it useful and gratifying and helpful and enlightening. But I felt that I had a lot of information that could help a broader number of people. So it's good to hear the feedback that it's doing some of that. Yeah, so Percocet ZH says, is gun ownership an independent factor for suicide? So absolutely, having a gun in the household increases the risk of accidental deaths, increases the likelihood of murder happening, and increases the likelihood of suicide separate from demographic, age, depression, physical health, other conditions. Um, so, I mean, and it's a place where intervention would almost certainly save lives. So the situations demographically where suicide public health measures save lives are those where the method of death is highly lethal and highly accessible. And that perfectly fits guns, which are available in the household, often without trigger locks or locked in a safe box, so can be accessed within seconds to less than a minute. So, and again, it highlights that at a social level, it's not just despair, it's not just depression. Impulsivity is a huge contributor to suicide deaths. If that weren't the case, again, restricting guns, or in parts of Southeast Asia where suicide by poisoning and taking insecticides was a major cause of death, just making those insecticides less readily available. If that clearly didn't treat despair, it didn't treat depression, it didn't make anything go away, and made it so that some people who were making an impulsive decision, even if it was a sad, despairing impulsive decision, the impulsivity amount or aspect is what's being addressed. Or when in Britain, and this wasn't intended primarily as a suicide reduction measure, but it had a measurable, sizable impact when they switched from coal gas to natural gas. Both can be lethal, but you need much more time. Natural gas is less lethal. So many fewer people died from sticking their head in the oven after the switchover came. And again, the switchover didn't change rates of despair, didn't change rates of depression or anxiety or PTSD. All it did was help make it harder for some people who had made impulsive decisions to quickly kill themselves. So I should be stopping soon. It's over an hour, but I see one or two questions left, so I'll try to get to those. James Alexander, do I believe PSSD, post-SSRI sexual dysfunction, is real, and use of antidepressants can cause permanent sexual dysfunction, such as low libido and erectile dysfunction in a tiny share of patients? What I can see is I've treated several hundred people with antidepressants. SSRIs absolutely can cause direct actions, and usually it is quite direct. And by that I mean one of the very few examples that's been extensively studied of taking drug holidays for any reason or rational is taking them for SSRI-induced sexual side effects. And the studies show very consistently 1 or 2 days break, which allows drug levels of most of them, not Prozac, to drop dramatically. The vast majority of the time, that resolves sexual side effects for that window of time, and then they go back to being present when the person resumes their dosage. So my experience is almost always sexual side effects are directly linked to taking the drug. The other thing to emphasize is that with sexual side effects, there's huge, with sexual performance, there's huge feedback loops between expectations and prior experiences and what you think and what you're going to get. And so I certainly think it's possible. I mean, anything is possible. I think it's possible that some people do have ongoing sexual issues after having stopped or gotten off an SSRI. What I can say is I haven't seen any. And so I think it's quite uncommon. And the other thing is just general aging. As we get older, it's not that we become asexual as we get older, but sexual desire tends to decrease, sexual performance tends to decrease, sexual lubrication and engorgement tend to decrease. So so for many of these people, if they're stopping medication 10 or 15 years after they started it, it would be surprising if sexual performance was in the same place. So Ian Fraser says, I first saw me on the David Pakman show and appreciates the video there and here. I mean, that's still where I reached the most people, was more than 1 million people. It was on a political tone, and I do not think I was assertive enough in framing things in a mental health, because that was a political context, but some valuable information there anyway. Yeah, so of the SSRIs, paroxetine Paxil is clearly the most likely to have sexual side effects. And again, but most often it's transitory. So dog's name is Cupcake, Mr. Cupcake. Yes, he's Mr. because people misgender him all the time. And he just turned 14 this week or this month. He was a rescue dog, so we don't really know when he was born. So Philip, I'm going to defer till later. Differences between DSM-5 and the ICD-10 way of diagnosing ADHD. I'm just going to defer that one. So stay healthy, stay happy, and hopefully you'll be back next week and you'll let your friends and your treatment community know about this. So that's all. Bye.